G. Vijayakumar, the Organizing Secretary of the 3D 2023. Dr. Vijayakumar has always been very kind to me and he has been inviting me for almost all his meetings. I've always found that his meetings are of a very high caliber and also very practical and clinical. And I'm sure that this edition will also be like this. Congratulations to you, Vijayakumar. I'm so proud of you. Keep up the great work that you're doing. I'm going to talk on a topic on which I don't normally talk about, early gestational diabetes. What does it mean? Now, the reason I'm going to talk about it, I think we have some new data, some of it which I can share with you, and some of it probably will be online and published quite soon. So, what is early GDM? Gestational diabetes mellitus, as you all know, is normally diagnosed between 24 to 28 weeks. In fact, the American guidelines, European guidelines all say that if you want to look for GDM, only look in the 24th or 28th week. Before that, if you want to do, it's just to rule out pre-existing diabetes in the first trimester. They are not talking about first trimester or early GDM at all. But what happens if GDM occurs before 24 weeks? This is called as early gestational diabetes mellitus. This is a term which we have coined and it's now becoming quite popular. It's also called as eGDM for short. So just to distinguish this eGDM from the conventional GDM, we have given two terms. One is called cGDM, which is conventional GDM, diagnosed in 24 to 28 weeks of gestation, and eGDM is diagnosed early. We don't have a strict definition for it, but it's at booking. Normally in India, it's below 12 weeks. Sometimes it can be 14, 16 weeks, but definitely in the first trimester of pregnancy. How do you diagnose early GDM? Now, when you do a blood sugar, fasting blood glucose, to rule out pre-existing diabetes, obviously if the fasting is more than 126 or HbA1c is more than 6.5, this is pre-existing diabetes. Even if you have pre-diabetes, it could be pre-existing pre-diabetes. Now, based on the HAPO study, in 2021, the IADPSG proposed a diagnostic criteria. What they said was that if the fasting plasma glucose is above 92 but less than 126, this is early GDM. Later on, they have revised it, and based on the latest studies which are coming, to talk about the toboggan study, this may get revised a little bit more. So, as we speak now, early GDM, we all know it's there, but we really don't have a good hang of it, and we also don't know what to do with it. And I hope to throw more light on this as we go along. Now, one of our PhD students, Hannah, she's doing a PhD exclusively on early GDM. Now, where is her cohort from? Her cohort is based on what is called as the STRIDE study. Now, STRIDE study is being done by us in collaboration with Dr. Saravanan Ponuswamy, whom you can see here. He is a professor of diabetology at the University of Warwick, and he is one of her supervisors. But her main supervisors for her PhD are based at Deakin University in Melbourne, and you will find their names here: Kevin McNamara, Vincent Versace, Eric Martin. These are the people who are actually guiding her for her PhD, and of course, I am her guide as well. We're very happy that Dr. Umaram is our obstetrics colleague, and of course, we have our own team, Anjana and Dr. Deepa, and of course, Hannah Bex, Baudarni, and others. So, this is a systematic review which Hannah wrote, trying to compile every paper published on early GDM to see what is known. And what we found is very interesting. There are 58 studies, and of these, 41 were on prevalence. And look at the range of prevalence. It varies from 0.7% to 36%. Obviously, this is because of different diagnostic criteria being used. One criteria will give low prevalence, another will give high prevalence. That is why it's time now to kind of standardize this early GDM. Risk factors for early GDM from all the systematic review that we did was BMI, previous history of GDM, family history of diabetes, and multiparity. These came out. Now, we further looked at in the systematic review, Hannah looked at the birth outcomes, and 23 studies reported on macrosomia, cesarean delivery, induction of labor. Now, what also came out clearly from that systematic review is that the need for insulin was higher than in the conventional GDM. And postpartum, if you look at the development of pre-diabetes, diabetes, that is also higher in those who had eGDM compared to normals or even compared to the conventional GDM. Now, some more points came out from this that the eGDM with a lot of ifs and buts, showing that more studies need to be done. Then came out this particular meta-analysis of 13 cohort studies, which showed that there is a greater relative risk among people with early onset GDM compared to late onset GDM. So these people didn't use the term conventional, they used the term late onset. So perinatal mortality, neonatal hypoglycemia, and insulin use was higher. This is exactly what we showed in our systematic review as well. Let me now pass on to what is called as the STRIDE study. STRIDE is an abbreviation for stratification of risk of diabetes in early pregnancy. What we aimed to do initially in STRIDE was to screen all women during the first trimester and then see how many of them will develop GDM in the second trimester, and going back, can we develop a kind of a risk score for GDM? That was our initial intent. But it turned out that when we started screening, there was a lot of early GDM also. So this gave us a chance to compare early GDM with the conventional GDM. And this is one of the largest studies on GDM done in India. About 3,000 women aged 18 to 50 years recruited before 16 weeks of gestation. I would humbly submit that this is probably one of the largest series in the world on early GDM. Now, the investigators for this are Professor Saravanan Panaswamy, and I told you Dr. Umaram is our collaborator. We also have sites from Chennai. We have the Sitapati Clinic and Hospital EV Kalyani, but also Andhra Mahila Sabha, VHS in Chennai, Fernandez Hospital in Hyderabad. There are two hospitals and they are both collaborating. Plus, we have JIPMA in Puducherry. So you can see that a lot of government, quasi-government, plus we have private, charity-driven. So it actually represents all the socio-economic strata of society. What we did was that we did a fasting glucose. If it is the diabetic range, we excluded that. This is called diabetes in pregnancy. If it is normal, below 92, we did one more GGT in the 24 to 28 weeks. And if that time they had GDM, we called it as conventional GDM. That time also, if it is normal, we called them as normal glucose tolerance. Now, if in the first trimester, the blood sugar is between 92 to 125, we call them as eGDM. So now we have three groups. eGDM, diagnosed first trimester, cGDM, conventional GDM, diagnosed second trimester, and then of course, normal glucose tolerance. You compare these three, you can see very easily here, and the numbers are quite large, as you can see. If you see the age, booking weight, BMI, waist circumference, blood sugars, HbA1c, all higher in the eGDM. Now that is why they're getting it early, and they're all statistically significant. So they have a more severe form. Even the A1C you can see not significantly higher. I mean, it is significantly higher, 5.1, 5.2, 5.3. So there are significant difference between the cGDM and the eGDM. Now, what are the risk factors for eGDM in STRIDE? Booking HbA1c. If your HbA1c is higher, you get eGDM. Then BMI, previous history of GDM, history of GDM in the family, all these came out as significant risk factors. Now, how do we screen for early GDM is another question. Do we do selective screening? That's what the ADA recommends. Or should we do universal screening? Now, if you look at ADA, they talk about the selective screening, but look at point number 3. Member of ethnic group with high diabetes prevalence, South Asian, they put. So they are suggesting that South Asians should have a complete universal screening of all pregnant women. They themselves are saying it. Therefore, it's not surprising that in the DIPSI guidelines, which were published in 2006, almost 17 years ago, DIPSI has already recognized that all pregnant women need screening. Of course, they're not talking about early diabetes screening here, but they're saying that everybody should be screened. So it makes sense that if you don't want to miss early GDM, you should diagnose everyone in the first trimester, and I completely agree with the DIPSI guidelines. Now, which test to use for early GDM is still a matter of debate, and it still needs more work. Will you do an OGTT? And if so, will you do a one-step OGTT or two-step OGTT? Will you just do a fasting glucose, or will you do a random glucose, or will you do a HbA1c? I think more randomized clinical trials are needed in early GDM, as has been done in the conventional GDM. Now, I'm going to talk to you about a very important study, which is going to be a game changer as far as GDM is concerned. This is called as a toboggan study. Toboggan stands for Treatment of Booking Gestational Diabetes Mellitus. I told you that very little is known about early GDM, especially what to do if you diagnose early GDM. There is no evidence at all. The systematic review and all are based on some observational studies done randomly. We gave all funny results. You have to do an RCT. You pick up women with early GDM, treat one group, don't treat another group, and see what happens. That's the only way that we can actually show evidence that treatment is, number one, beneficial, and number two, safe. Sometimes we start treating them too early, they may cause harm. So that is what toboggan was all about. The first multi-center RCT for the diagnosis of hyperglycemia in women before 20 weeks of gestation. And we want to understand what happens if you treat this early GDM. Now, when the HAPO study was done and the IADPSG criteria were established, there was a criticism that there are no Indians in this, there are no South Asians in this. So we wanted to, in toboggan, we wanted to see that there's good representation from India. So from the Sitapati Clinic and our MDRF, myself and Anjana and Umaram are actually collaborators on the study, and we have provided the data on our early GDM. So India is very much part of this. Apart from that, this time they were careful. They've included a lot of South Asians from Australia itself. Most of the collaborators are from Australia, but we also have some people from Austria, Sweden, and from India, of course. 16 sites. We take women with in whom there's no pre-existing diabetes. And for toboggan, because it's mostly based in Australia, we didn't do universal screening. We took those with the high risk. That means BMI more than 30, past history of GDM, macrosomia, first degree family history of diabetes, or ethnicity. These women then underwent the following tests. Just like we did in STRIDE, what was done is that we did an OGTT in the first trimester. Now, if you had pre-existing diabetes, they were removed. Even if they had fasting more than 110, because that means pre-diabetes, they were also excluded. Now you're taking people who don't have diabetes, don't have pre-diabetes. And then we did the GTT. Now in them, using the IADPSG criteria, we diagnosed GDM in some. What we did was, those who had GDM, we had 400 in the intervention arm, where they are going to be treated. 400 in the control arm, although they have GDM, we're not going to treat. We're just going to follow them up and see what happens. You may say, is it ethical? Well, there is no guideline how to treat. So how do we treat unless you do an RCT and prove it? Suppose you do harm by treating too much. So therefore we can't. This is the definitive study. In a definitive study, until the study is published, it is ethical. Once the study is published and shows some good results, it will become unethical not to screen. That is how the entire medicine progresses, and that is how progress in medicine always occurs. So we have a control group and we have intervention. It's a proper RCT. Now what we did very cleverly was, we also included some women who did not have GDM and took them through the same protocol. They call as decoys. Why should you have decoys? Because sometimes just putting women in a trial will make them better, okay, and they'll have some benefits. So to see whether this effect that we're seeing due to intervention is simply a placebo effect or not, we had the decoys. And then of course there are women whom we didn't do anything, we just left them alone also. That's a non-active group. Now, unfortunately, I'm not able to show you all the tables in this graph. The reason being that toboggan has just been accepted for publication in the world's #1 journal, New England Journal of Medicine. I'm very humble that we have been included as authors in this, as primary authors in the NEJM paper. Therefore, in a major game-changing study which is there in the field of GDM, India will have a representation as well. And so that is something which we are very, very happy about. But NEJM has not yet published it. It's just accepted it. Now the proof stage is coming and it's going to become online. So they've given strict instructions not to publicize or present the data. NEGM is very strict about it. So we'll have to wait for another. Unfortunately, if it was just 2 or 3 weeks later, probably I could have presented, but let's wait for it and you can see the results in NEGM anytime now. But I can just tell you what we found. We found that there is benefit in treating eGDM. For the first time in the world, we are showing that treating eGDM is good. The natural history of early GDM is also well defined because one group we did not treat at all. One group there was decoy group. So we know exactly how the natural history of early GDM is with treatment and without treatment. And then it also showed that there were no side effects. Okay, so it is safe. Now, further toboggan, after the New England Journal paper is published, we have some more papers submitted to ADA, EASD, and others, and to DIP meeting, the diabetes pregnancy meeting in Greece next year. Series of publications looking at cost effectiveness, diagnosis, treatment, and various methods, and various papers will come out from toboggan. And I'm very happy that India is part of that. So I'm going to end, ladies and gentlemen, by saying that these are my take-home messages. Early pregnancy blood glucose screening for GDM will now become mandatory. You have to do that. We've always been saying it in India, but now the whole world will start saying it, as it helps in identifying pre-existing diabetes and also early onset GDM. Obviously, more work is needed. Now, this is opening up a whole new field in the case of GDM. So, more work is needed. How to screen, who to screen, what method to do, is metformin better, insulin better, which insulin to use, which at what level will start insulin, what happens to them during the later part of pregnancy. All these will need series of additional studies to be done. So early GDM is really going to take off after toboggan results are published. But it's now clear that early GDM must be diagnosed and treated as the pregnancy outcomes can be improved. So my take-home message to you is early GDM is a definite entity, number one. Number two, it must be identified. Number three, it must be treated. Now you can continue the treatment as you would treat, maybe with diet, exercise, in severe cases with insulin. That is left to you until more guidelines come. But this is my take-home message to all of you that early GDM or eGDM is now a real entity and it must be identified and treated. And with that, I would like to stop by once again thanking Dr. Vijayakumar for organizing this excellent meeting. And I hope that this talk has been useful to you. Thank you very much.